Folks, so we're going to wrap up with, for the last presentation, is something special. It's really, for me, it's kind of funny. Dr. Ross was my neurologist for many years, and a couple of years ago when I was working up the symposium, I actually was going to take him off the speaking order because I wanted to address something else, and we just didn't have enough time to do everything. And then when I met with my board and proposed it to them, thought I was going to get hit because they almost rebelled on me and said, no, you got to put Dr. Ross on because he's just a tremendous speaker. So let me do the official introduction. Here today to give us a research update is Dr. Webster Ross, the Associate Chief of Staff for Research and Development and Staff Neurologist at the Veterans Affairs Pacific Island Healthcare System here in Honolulu. Besides being a research neurologist for the VA, he's a clinical professor of neurology and geriatrics at the University of Hawaii's John A. Burns School of Medicine. Dr. Ross has been involved in clinical trials of symptomatic and potential disease-modifying therapies for Parkinson's disease as a principal investigator with the VA-affiliated PHREI for over 20 years. Ladies and gentlemen, it is my privilege to present my good friend, Dr. Webb Ross.
Thank you for that introduction, and thank you for inviting me. I might be the grand old person here. I've been coming to these, I think, since they started in the mid-1990s, and what has struck me is that every year they just keep getting better and better. And I just want to say congratulations to Jerry and the Hawaii Parkinson Association and all the providers up here and the excellent skits that were done. This has just been another spectacular symposium, and I'm just really proud to be a part of it, and I'm proud to be part of this community. So, big hand to you guys. So, as Jerry said, I'm going to talk a little bit about research, and I'm going to focus on research related to the theme of today, and that's mental health disorders. But then I'm going to actually expand a little bit beyond that towards the end of my talk, and I'm going to talk about a couple of clinical trials that have been ongoing here in our state and opportunities for clinical trials and participation in clinical trials. Because somebody asked a great question: what can we as a community do now to push our field forward and to try to find a cure and a prevention for this condition? And I think participating in research is one of those ways. So I don't have any disclosures right now. I retired from the VA and about 8 months ago, and I'm very thrilled to be doing research at Pacific Health Research and Education Institute. And as I said, I'll be talking a little bit about research related to mental health disorders, and I'm going to start out actually by talking about a study that I think is really pushing the field forward and contributing not just to mental health disorders, but to finding ways of diagnosing and identifying people at high risk for developing Parkinson's disease, and that is the Parkinson's Progression Markers Initiative Study, or PPMI. And this is a study that actually has been going on for over 10 years now. It's a national study. There are over 33 clinical sites, 11 countries are involved. It's sponsored by the Michael J. Fox Foundation, and the whole goal of this is to enroll people with Parkinson's disease and who do not have Parkinson's disease and collect data and collect specimens like blood and cerebrospinal fluid and do brain imaging to try to determine what factors may help us to predict the onset of Parkinson's disease and what factors may help us predict how quickly the disease might progress, and even what kind of interventions we can do to stop that progression. So I think one of the important things about my mentioning this today is that this study continues to enroll people. And in fact, you can go to the Michael J. Fox website And you can enroll in this study today. You just go right to Michael J. Fox Foundation website. The PPMI study will pop up. You just click on that and go on and enroll. And if you don't have access to the internet, I'm sure that you have a friend or a family member that could help you give you access. This study has been really responsible for so many wonderful papers on blood tests that might in the future predict Parkinson's disease, on cerebral spinal fluid analysis and tests that might help us predict future Parkinson's disease, and neuroimaging. But I'm going to talk about a particular study that has recently been published that talks about the neuropsychiatric symptoms and cognitive abilities in people with Parkinson's disease. And in this is a study that used the PPMI database, and this study compared the frequency of 10 mental health symptoms in about 400 individuals with Parkinson's disease who were participating in the study, and they compared their responses to about 200 people who did not have Parkinson's disease to look at the frequency of each one of these 10 symptoms in Parkinson's compared to people who did not have Parkinson's disease. And then, importantly, they reassessed those same individuals 5 years later to see how the frequency had changed in each one of those groups. So what they found was every single one of those 10 symptoms, and I'll just name them. The mental health symptoms that were measured were major depression. You've heard about all of these today. Anxiety, psychosis or hallucinations, apathy or loss of interest, insomnia, fatigue, which is a really debilitating, and some people would say mental health symptom, sleepiness, rapid eye movement, sleep behavior disorder that you just heard about in the last skit, impulse control disorders, which are mental health disorders that we generally associate with Parkinson's disease medications like the dopamine agonists. And these medications can be associated with impulse control problems such as spending money excessively or eating excessively, and they can lead to a lot of problems in the family, and patients generally don't like to talk about them because they're uncomfortable with them. And so they're symptoms that the providers must bring up when they start people on these medications. And then cognitive disorders or disorders of memory and concentration, including mild cognitive impairment and all the way up to dementia. So all of these symptoms were assessed in this PPMI project. Every single one of those symptoms were more common in people with Parkinson's disease than they were in people without Parkinson's disease. So that right there should tell you something. Everything that's gone on to this point in our symposium today is more common in people in Parkinson's disease, and it is vitally important to understand these symptoms and to seek help for these symptoms and to fold the caregivers and family members in on recognizing these symptoms and getting treatment for them. So. And then when they reevaluated people 5 years later, what they found was that every single one of those symptoms, except for anxiety, became more frequent among people with Parkinson's disease. But when they looked at those same symptoms 5 years later in people without Parkinson's disease, what they found was that the frequency actually went down. So these symptoms continue to become more frequent and to continue to be problem in people with Parkinson's disease, and that's why I just think this symposium has been so valuable. So that kind of gives you an introduction to some of the things that I'm going to be talking about for the rest of the 15 or 20 minutes or so. One thing that hasn't been mentioned a great deal this morning is cognitive impairment and dementia. And when I say cognitive impairment, I mean decline in memory and decline in other areas of cognitive function like language and visual spatial ability. But when I say dementia, I mean that that decline is severe enough that it's beginning to interfere with functioning ability. So mild cognitive impairment is a syndrome that we recognize as just having problems with memory or problems finding the right word or difficulty sort of navigating in space, but not so much that it interferes with social or occupational functioning. So about 40% of newly diagnosed people with Parkinson's disease will have some kind of cognitive impairment. And generally speaking, this kind of gets worse over time. So that if you take, there's been a very good study out of Australia that looked at several hundred people who had newly diagnosed Parkinson's disease, and they evaluated their cognitive function, and then they followed them over time for many years. And what they found was nearly 80% of those individuals developed severe cognitive impairment and dementia by the time they had the disease for greater than 5 years and up to 10 to 15 years. So cognitive impairment is really as much a part of the Parkinson's disease syndrome as all of those motor features. And in fact, it's a characteristic that really interferes with quality of life, and it's one that really deserves to be addressed and to be treated if possible. Dementia, at any given time, if you just took a cross-section of people with Parkinson's disease, probably about 30% of them at any given time will have dementia. So again, this is a really important component of the condition. We have had treatment for dementia in Parkinson's disease for a long time, and these treatments really depend on treatments that have been developed for Alzheimer's disease. And one of the nerve chemicals in the brain is called acetylcholine, and it is very much involved in making new memories in the brain and helping memory cells function efficiently. And we know that in Alzheimer's disease there's a deficiency of acetylcholine, and so medications that we have developed now boost the presence of acetylcholine by preventing the breakdown of it in the brain. And it just so happens that this condition also occurs in Parkinson's disease. So these medications that seem to help memory in Alzheimer's disease also help memory in Parkinson's disease. And specifically, donepezil and rivastigmine have been tested in placebo-controlled randomized trials and have shown to be of some benefit in memory function, and in some cases in benefit with quality of life. So unfortunately, the memory condition continues to decline with time, and these medications become less effective. So really, we're looking for interventions and ways of managing Parkinson's disease that prevent the cognitive decline or at least slow down the progression of the cognitive decline. And there are a lot of different experimental medications that are doing this, and a lot of different strategies. And one strategy that is being developed is a way of blocking the abnormal clumping together of a protein called alpha-synuclein. And probably most of you know that alpha-synuclein is a protein that normally occurs in the brain. We don't know what the function of it is, but we do know that in people with Parkinson's disease, there's something that triggers this protein to clump together and deposit itself in these little tiny lesions in the brain called Lewy bodies, after the neurologist that described them nearly 100 years ago. And there's pretty good evidence that these forms of alpha-synuclein that are clumped together and form these Lewy bodies can be toxic to nerve cells. So there is a whole arm of therapy being developed, immunotherapy and medications that prevent clumping of this protein, that's being developed to try to slow down the progress of Parkinson's disease. And I think that this is really exciting research. It does hinge on this idea that alpha-synuclein clumped together can be toxic, and we don't have direct proof of that yet. But I think that this is a really promising field for actually having something that will modify disease progression or slow disease progression, including a cognitive impairment. So one of these compounds that I think is really exciting, it's called ENT-01. It's still experimental. It is a synthetic version of a protein called squalamine that occurs in the gallbladder and liver of dogfish sharks. And it's been shown in the laboratory that this ENT-01 is a very potent inhibitor of clumping together of alpha-synuclein. And the only problem with this ENT-01 is that it does not cross the blood-brain barrier. So the blood-brain barrier is this barrier of cells that keeps toxic substances out of the brain and keeps good things in the brain. And it's a very tight barrier, and it's very important that when we have drugs developed, that these drugs, if they're developed for a nervous system condition, they have to be able to get into the nervous system. Well, this ENT-01 just won't cross the blood-brain barrier. So the researchers who develop it, they said, well, okay, we can't use it for Parkinson's disease, it's the motor symptoms, but let's try it for constipation in people with Parkinson's diseise. Because we think that the constipation that's present in nearly everybody with Parkinson's disease is related to deposits of Lewy bodies and alpha-synuclein in the nerve cells of the gut. The gut has a very rich nervous system that regulates peristalsis and transit of food and fecal matter all through the GI tract. So it was thought maybe we could just try this drug and see if it helps with constipation. So they did some phase 1 trials. Phase 1 trials are trials that are looking at safety and tolerability, and this medication was safe and tolerable. And then they launched into a phase 2 trial. This is called the Carmet Trial. And what they found was very interesting. It did help constipation in people with Parkinson's disease, but it also had a very mild but still significant signal of helping psychosis that you just heard a lot about in people with Parkinson's disease and dementia or cognitive impairment. So this has actually led to a phase 1 trial of ENT-01 for dementia in people with Parkinson's disease. Now, I told you that it didn't cross the blood-brain barrier, so I personally don't understand how it could help these other conditions, but in fact it did. And so I think in the next 4 or 5 years, we're going to have some exciting news about perhaps a medication that will be effective in preventing or slowing down dementia in Parkinson's disease. There is another class of medications that are being developed that actually slow the progression of Parkinson's disease by boosting the production of energy in the cell. So cells have all kinds of little organelles, we call them, that have different things. We have organelles that get rid of bad substances, and then we have organelles that are called mitochondria that actually generate power in the cell. They generate the fuel, and the fuel that they generate is called ATP. And we know that in Parkinson's disease, for some reason, these mitochondria are inhibited, and they are not as efficient as they used to be in producing energy and ATP. So along comes a medication that has been approved for years for high blood pressure and prostate enlargement in men. The name of the medicine is terazosin. So somehow, and I'm just not familiar with how this was discovered, but somebody got the idea to look at terazosin in cell cultures in the lab, and what they were able to show was that terazosin in cell cultures boosted mitochondria and improved the production of power, of energy in the cell. And so this led to observational studies that looked at the association of progression of Parkinson's disease with people taking terazosin compared to people who didn't take terazosin. And this is another very important study that came from the PPMI study, sponsored by Michael Fox, that I just talked about. And in this trial, the investigators looked at men with Parkinson's disease who took terazosin and compared them to men who had Parkinson's disease but did not take terazosin. And in fact, they were able to show that those men who took terazosin had a slower progression of Parkinson's disease. So this led to a small phase 1 safety and tolerability trial that showed that terazosin could be safely given in people with Parkinson's disease. And so now there are future trials being planned for clinical Parkinson's disease as well as dementia with Lewy bodies, which is a form of Parkinsonism that's associated with dementia. So I think that this is another really exciting topic. I'm going to move now to hallucinations. We've had an excellent discussion of hallucinations, visual hallucinations and psychosis and delusions. And Dr. Bruno has already informed you that these can occur in 30 to 40% of people with Parkinson's disease. They're usually visual, but they can be auditory or olfactory or tactile. And as Dr. Spira said, they can range from just simple fleeting hallucinations like a shadow passing to very complex hallucinations of water coming off the ceiling or animals running underneath the bed or people. And they can, people can realize their hallucinations and blink and they'll go away, or sometimes they really become very entrenched in the belief that the hallucinations are real. And there are, our speakers today already alluded to risk factors for some of these hallucinations, and one of those is impaired vision for visual hallucinations, older age, longer duration of disease, and of course, medications, the dopaminergic medications that we use for Parkinson's disease. So I think one of the things that really came out very nicely in the last skit was, when do we intervene for these hallucinations? And the threshold has to be individualized, and it really depends on safety and comfort, not only of the person with Parkinson's disease, but their environment and the people, their caregivers in that environment. So I'm not going to say anything more about when to intervene, but I will say that it really should start, and the speakers alluded to this as well, we usually start by modifying the Parkinson's disease medications. At some point in time, we have done all the kind of modification that we can, and these hallucinations are still a major problem for the person. And so we really then begin to think about antipsychotic medications. And as Dr. Bruno stated a little while ago, these antipsychotic medications can have serious side effects, including making the Parkinson's disease worse. So we definitely don't want to do that. The more recently developed antipsychotic medications, such as quetiapine and pimavanserin, are medications that don't really block or they don't have an effect on dopamine in the brain. They act on other nerve chemicals such as serotonin. So they don't have the Parkinsonian side effects as much as some of these older antipsychotic medications like haloperidol. So when we really have to, and we really don't like to, but when we're really faced with no other option, and we do use medication, medications such as quetiapine have been shown to be effective in people with Parkinson's disease with hallucinations. And then there's a medication that was released about 4 or 5 years ago called pimavanserin that was actually specifically now has an indication for psychosis in people with Parkinson's disease. We still don't know what the best medication is, however. And so there is now a new study that is a multi-center cooperative study, a clinical trial that's being sponsored by the Department of Veterans Affairs that's looking at the efficacy of quetiapine versus pimavanserin versus placebo in the treatment of intractable psychosis in people with Parkinson's disease. So this trial is just getting started, and I hope that we have some good answers that will lead us to better ways of treating hallucinations in the next 4 or 5 years. So again, another symptom that has been really discussed very eloquently this morning is major depression. And we have effective treatments for major depression. And for me, that starts with talk therapy. And when I have discussions with patients and they endorse mood symptoms like sadness of mood or loss of interest or fatigue or loss of energy, appetite change, and so on, we talk about this, and I'm very quick to refer them to a mental health professional who may initiate some kind of talk therapy, like cognitive behavior therapy, and this has been shown in randomized placebo-controlled trials to be very effective. We have a long list of antidepressant medications. The newer antidepressant medications really work on the neurotransmitter serotonin. Again, this is a chemical that helps make cells involved in mood act more efficiently. It carries the nerve process from one cell to the next. So we have medications that boost that serotonin, and then we have medications that are called tricyclics that have been around for years but are still known to be very effective medications for treating depression, major depression in Parkinson's disease. And one of these tricyclic antidepressants is called Nortriptyline. And Nortriptyline has been around for over 40 years. When I was a kid in medical school and treating major depression, it was one of the first medications that I became familiar with. Now, Nortriptyline has some pesky side effects. It can cause dry mouth and dizziness and sometimes blurred vision. But it is a very potent antidepressant. And so one of the very interesting things about Nortriptyline is that somebody made the very astute observation that people with Parkinson's disease taking Nortriptyline seem to have a slower progression of their Parkinson's disease. So this actually started people to looking at taking Nortriptyline, which has been around for almost 50 years, taking it back to the lab and looking to see what effects it had in cell cultures in cells that are involved in Parkinson's disease. And what they found was that Nortriptyline in these cell cultures actually reduced clumping of that alpha-synuclein that actually can be toxic to nerve cells in Parkinson's disease. So, to me, this is just amazing. This idea of repurposing medications that are already on the market and already time-tested and true and found to be safe can be developed for a separate kind of indication and used maybe to slow down the progression of Parkinson's disease. And in fact, there is now an ongoing phase 3 placebo-controlled clinical trial that is actually establishing the effectiveness of Nortriptyline versus a serotonergic antidepressant called escitalopram for major depression in PD. But that's only the first part of the trial. The second part of the trial is to examine the potential that Nortriptyline might have to slow down the progression of Parkinson's disease, to delay the motor symptoms, the progression of the motor symptoms of Parkinson's disease. And I think this is really exciting. I think in the next 4 or 5 years, we may get the results of this trial, and it'll be really exciting to see how they come out. There is some other really very interesting research in the treatment, of depression in Parkinson's disease. And these have to do with hallucinogenic compounds. And of course, when we think of hallucinogenic compounds, we think of LSD and magic mushrooms and all these things that were going on back in the 60s. But actually, there has been a very quiet movement in mental health field over the last decade or so that is starting to look at the effectiveness of these medications for treatment of major depression. And what they found is there have been some amazing studies of treating intractable major depression with psilocybin compound, which is the active ingredient in magic mushrooms or hallucinogenic mushrooms. And then another medication called ketamine, which is an anesthetic that's commonly used in children that has a sedative effect and a potent hallucinogenic effect. So there have been really some very nicely controlled trials that these compounds can be helpful for people with major depression. Now, there is a caveat here. I don't want people to go out now and pick up magic mushrooms and take them if they feel like they're depressed. These are still experimental medications, and they really need to be used under the supervision of somebody who understands them and knows what they're doing and knows what the safety profile of these medications are. And again, I want to emphasize they are all very experimental. So please don't go out and try these things on your own. Talk to your healthcare providers. But there are now a couple of studies that are specifically looking at psilocybin in depression in people with Parkinson's disease. And one of these is an open-label, single-arm, that's a pilot study or a beginning study of oral psilocybin in people with Parkinson's disease who are depressed. And I think we'll be able to have the outcome of this trial in the next 3 to 4 years, but it is ongoing. And then there's another study of ketamine. And as I said, ketamine, it's actually commonly used in children as an anesthetic because it doesn't have effects on breathing, but it does have some hallucinogenic effects and sedative effects. And so ketamine, there's another trial called KET-PD that is comparing ketamine infusions versus placebo infusions or non-active infusions in people with Parkinson's disease who have major depression. So I think it's going to be really interesting to see what happens with these compounds in the near future. I want to say a little bit about, before I just stop, a little bit about COVID-19 infections in people with Parkinson's disease and the effects on some of the mental health symptoms of Parkinson's disease. There have been several studies of COVID-19, just how it presents, how it manifests itself in people with Parkinson's disease. And as you would expect, people who have PD, who have COVID-19, their motor symptoms get worse, and they have more apathy, more loss of interest, more depression, and more cognitive impairment during the course of their illness, but they do get better. They also can have more hallucinations. So, and I think a lot of the hallucinations are just related to being sick, being ill. It's really unclear whether these worsening of symptoms are related to the virus itself, or just being sick, or just being in lockdown all the time. Obviously, isolation does a lot of powerful things to our quality of life. The good news, I think, though, about COVID-19 is that having Parkinson's disease does not seem to increase one's risk of developing COVID-19. And nor does it increase the risk of hospitalization or death, at least in the few studies that have been published in this area. And the other thing is that while there are isolated reports that COVID-19 has been associated with Parkinson's disease after the infection, so far there's really no long-term studies of COVID that show that COVID-19 will lead to Parkinson's disease. And I think this is important because, you know, when we think of Parkinsonism, oftentimes we think of the flu epidemic of 1919, of the early 1900s. And we associate a virus with sometimes wiping out the nerve cells in the substantia nigra that produce dopamine and producing a Parkinsonian syndrome. So far, we really don't have definitive evidence that COVID-19 will cause Parkinson's disease. And lastly, I just want to say that the benefits of vaccination are just as great for people with Parkinson's disease as they are for people who do not have Parkinson's disease. And it does not appear that people with PD have any more side effects than the general population. So all of the recommendations for the vaccine for COVID-19 still also apply to people with PD. One other thing that I kind of like to cover, because this always comes up in questions, and that is the use of marijuana for Parkinson's disease. You can go on YouTube and you can see miraculous cures in certain kinds of symptoms of Parkinson's disease, tremor and dyskinesias on YouTube. And you know, I mean, that may be very true. Michael J. Fox, to their credit, they recently did a survey of about 2,000 people with Parkinson's disease, and they asked a response to this survey. And when they just asked, how many of you use some form of marijuana, either CBD, which is the ingredient that is being used now for anxiety and for certain kinds of seizures and so on, and THC, which is the psychoactive ingredient, the ingredient that makes you high for marijuana, how many use it? And believe it or not, of the respondents, and of course this is not a randomized sample, so the people that participated probably were more likely to use some form of marijuana. But of the 2,000 or so respondents, 70% said that they use some kind of marijuana, either THC or CBD. The problem is that about 15% of those didn't know what form they were using. They all said that it kind of helped their anxiety, it helped them sleep better, it helped them rest. But there was no single Parkinsonian symptom that stuck out as being really benefited from the use of marijuana. And the side effects were very minimal, actually. It was very well tolerated. But sticking with the theme of today's conference, it was associated with impaired thinking and concentration and memory in people who took marijuana. So you have to be very cautious about that. And again, this is something to discuss with your provider, because, believe it or not, 30% of this sample, 30% had not discussed using marijuana with their neurologist, with their Parkinson's disease provider. And you know, if there's one takeaway point that from this conference today, is that these medications that we use have all kinds of side effects, and they have all kinds of interactions with other medications. So please discuss it with your doctor. So I'm just going to say 2 words about a couple of trials that went on here in Hawaii, and one of those is the P2B001. This is a combination medication of 2 medications that are already approved for Parkinson's disease, pramipexole and rasagiline. Pramipexole is a dopamine agonist. It's been around for a long time. It's safe, but at higher doses, it's associated with side effects like hallucinations and impulse control disorders. And then rasagiline, it's very safe. It has a very good safety profile, a few side effects, but it only has modest symptomatic benefit. So it was thought by combining these 2 medications in a long-acting, slow-release form that could have to be taken once a day, that you could actually boost the symptomatic benefit and still have a very good safety profile. And so this trial was a multi-center trial and multinational trial. There were 40 centers or so across the world. The company is actually based in Israel. And this was a trial to compare P2B001 with the 2 components of the medication, rasagiline and pramipexole. And the trial results were just released this past December. We were a site at the Honolulu VA, so some of you may have even participated in the trial. And we were very fortunate to be a site. And what they found was that this medication was as effective as a long-acting form of pramipexole. It was as effective as each one of the individual components, but it had a more favorable safety profile, and it caused less excessive daytime sleepiness. So that medication now will be submitted to the FDA for final approval. approval. And then I just want to mention one other trial that I believe is going on at Hawaii Pacific Neuroscience. This is here in Honolulu, which some of you may be eligible for this trial. And this trial is looking at a medication that actually kind of blocks the activation of another protein called LRK, or LARC protein. And we know that when LARC is excessively activated, it's excessively activated in people with Parkinson's disease. And we actually, researchers have identified mutations of the gene that codes for the LARC protein that actually produce more LARC than they should, and their risk for developing Parkinson's disease is greater than those people who don't have the mutations. And even among people who don't have the mutations, it seems that people with Parkinson's disease have more highly activated LARC than those that don't have Parkinson's disease. So there is now a medication that's been developed that actually blocks the activation of this medication, and it may slow down the progression of Parkinson's disease. So I just want to encourage you to go online, seek out these trials that may be going on in Honolulu, and if you're eligible, I'd urge you to participate. So that's all my formal comments. I got time. I'm sorry I talked more than I thought I was going to, but I think I have some time for questions. Do I?
Nice round of applause for Dr. Ross, everybody. Dr. Ross, I'm going to put you on this microphone.